represent the retired General CGDN Chiwenga, and also I would want to say honorable ministers. So allow me to express my gratitude to the host, yourself, Honorable Dr. Ruth Acheng, for inviting us to address this Regional World Health Summit meeting, colleague ministers of health and invited delegates. The SARS-CoV-19 pandemic has been with us for over a year now, and our health systems have faced a litmus test on the state of preparedness and resilience to manage the scourge of this virus. Early on the outbreak of the COVID-19 pandemic, we were all faced with inadequacy and scarcity of personal protective equipment, which included face masks, donning gowns, gloves, face shields, etc. The frontline health workers had to have adequate personal protective clothing to be able to handle the COVID-19 patients. Innovations and partnerships, both public and private, saw most of our systems managing to avail much of the needed PPEs to the frontline health workers. The second major challenge was on the service provision side. We faced the unavailability of ventilators and inadequacy of oxygen supply. Whilst Europe and the Americas were in the deep end of the crisis, we were going into a panic mode if we were to face the same. Fortunately, if I may say, the pandemic has not ravaged the African region as elsewhere, but we are not out of the woods as yet. India has recently suffered a deadly third wave, and we need to be more proactive. We need stronger partnerships on local solutions to the development of life-saving, affordable, and accessible equipment for our health systems. The tertiary institutions and industry need to foster partnerships that see the production of medical equipment in Africa, as we had to do with PPE. Biomedical sciences, engineering technology needs to be supported locally for our systems to be better providers of health care. Information, education, and communication is vital for the general population to be made aware of how to conduct themselves during this pandemic, such as COVID-19. Masking up, social distancing, regular hand washing, and sanitization have become a new normal to contend with. Formal and informal businesses have had to adjust on conduct and worker safety through testing of their staff and provision of the required PPEs and sanitizers. Our economies have gone through various levels of lockdowns as measures to contain the spread of the coronavirus. The effects, both business and livelihoods due to the lockdowns, has been devastating, and a new work culture has been adapted as means to adjust to the new normal. We have seen a growing use of electronic systems and a work culture. Telemedicine needs to be strengthened to reduce the interface of patients and medical staff. We need to develop software solutions that allow the virtual hospital concept to prosper. Ideal frameworks that enable faster access to medical support need to be encouraged. As we step up the vaccination campaign to achieve herd immunity, we need to harness local production capacity to bolster the COVAX facility that has been affected by increasing COVID-19 challenge in India. We need more vaccine options on the table, but we need to create the options for ourselves. Let's identify our own institutions in Africa that we can support to spearhead vaccine development and production if we are to succeed through COVID-19 and other pandemics that will come in the future. The establishment of the African Medicines Agency is a bold step in the right direction and towards sustainability and pharmaceutical sovereignty. Non-communicable diseases need to be profiled more as they have been the leading cause of death under this COVID era in our region. Let us have countries looking closer on how these conditions are being supported within their own health systems and put measures that improve on the access to care and assistive devices and commodities. Health and well-being is not just a concept, but be action centered across the life cycle and in the service provision within our health systems. I call upon a stronger and rigorous approach to managing non-communicable disease in the African region. Universal health coverage is a goal every nation intends to achieve. Let us define and fully fund essential healthcare benefit packages that cater for the health of everyone as and when they have need, then suffering financial impoverishment. Global security due to the impact of COVID-19 requires strong collaboration between and amongst nations. The new variants sparking new waves of COVID infections are casting longer notions of protracted periods we have to live with the virus. We need to be more alert to internal conflicts likely to stem from the most affected and vulnerable groups in our society. We need to be proactive to provide social safety nets to these groups such as women and children, the unemployed, the urban poor, migrants, the youth, and the disabled. As the African region, we need to step up collaboration on resource mobilization efforts and opening up of lines of credit to members to support and cushion business from the COVID-19 effects on production and employment. Food supply chains have to be kept running and reduce conflicts amongst nations to better manage this pandemic. We need to have a harmonized strategy on minimizing conflict internally and externally with a multifaceted socio-economic approach that can bring stability amongst ourselves. Let me reiterate the need for continued cooperation in the region, both on health matters and other areas that forms key determinants of our health. Honorable Minister Ruth Acheng, I'm sure this will suffice for now. Thank you, Honorable. Thank you, Honorable Ministers.
Thank you very much, Honorable Minister from Zimbabwe. That was quite very detailed. You brought out the challenges we met previously and what we need to do as Africa so that we can have Africa solutions. I picked up one of the issues that you talked about, and that was the need to have vaccine options on the table, but also ramp up our
No.
Dr. Honorable Acheng, we're not hearing you.
Honorable Minister, are you on?
The Honorable muted.
Can you hear me now?
Yeah,
Yes, you can.
You can hear me.
yes,
Yes,
now we can
Honorable.
hear.
Yes, so I'll just go back to where we were. I was saying that less than 1% of the population of Africa is vaccinated compared to 40 to 50% of vaccination in some countries and continents. So Africa is definitely lagging behind. We need to vaccinate our populations if we are going to safely open our economies during this very difficult time of the COVID pandemic. Most of the production of vaccines is not in Africa. And I recall during the opening ceremony, the WHO Director General was very clear that there needs to be mechanisms of technology transfer so Africa can start manufacturing vaccines. But turning to Dr. Monica Musenero, Uganda has been putting in a lot of efforts to begin manufacture of its own vaccines during this time of COVID-19. Would you like to share with us your ideas on how Africa can come together as African countries to address the challenges of vaccine availability and vaccine production, and also what we can do during this time to ensure that we also begin to open up our economies, because definitely we cannot keep our people locked up forever. Honorable Monica, you have the floor.
Yeah, thank you, Honorable. As we heard from Hidense in the opening ceremony, right from when COVID was threatening Uganda last year, work on tools going beyond just vaccines, because at that time we didn't have capacities and sanitizers. We had some limited capacity, but led by the president, he has been pushing for local production as much as possible of the solutions, at least to increase availability. Also an initiative which assigned to me to make sure
I don't know what we can do about this network. Honorable Monica, we've lost you. Honorable Monica, we have lost you. Professor Tony, could you help us out there? We've just lost our speaker.
Yes,
Oh, she's
Madam,
back.
we are following up the matter technically. I would also like to inform you that we have been joined by the Minister of Equatorial Guinea. When you can, you give him a chance to offer his statement.
Right. Honorable Monica is back on.
She's back on.
Honorable Monica, you have the floor.
Can the Honorable unmute? She's back, but she needs to unmute. Again, she's off. I understand she may be having problems with her network. Honorable, you may maybe give the Honorable Minister from Equatorial Guinea a chance as the network is sorted out for Honorable Monica.
Okay, that was a very unfortunate incident, and Honorable Ministers, Your Excellencies, I do apologize for that. In the meantime, allow me to say a very warm welcome to the Honorable Minister of Health from Equatorial Guinea, I had opportunity to meet you during the opening ceremony, and I must say we are happy that you could come to Uganda and share your thoughts during this World Health Summit. We are discussing the challenges African countries face.
Honorable Internet sabotaged my submission. I don't know if I can have a Honorable Chen.
Yes, Honorable Monica, if you're back on, we'll give you that opportunity. Go right ahead.
Can I continue?
Yes, continue. Continue, but we are not getting you clearly.
Okay, sorry. Struggling with these issues of technology. So I was saying that we have initiatives concerning vaccines. We have the local manufacture of vaccines locally developed. We started working on 4, 3, 2 have reached animal trials. However, we are also working in a concern with other people who already have approved vaccines been taken place. The president has approved to the honorable minister, and we're in the process of getting the funds and also getting the partners who provide technical support to make sure that we can manufacture vaccines, both ours locally developed, but also the finishing it.
It is quite unfortunate. Professor Tony Oyana, I request that you put a call through to Honorable Monica and see if we can sort out the challenges she's having with her internet. She was definitely discussing a very important topic, and that is vaccine development and ramping up production in Africa. Allow me to invite the Honorable Minister of Health from Equatorial Guinea to come out and share his thoughts with us. As Professor Tony, you sort out the issue of Dr. Monica. Honorable Minister, you're most welcome. You have the floor.
Thank you very much. I came mainly to share the experience of Equatorial Guinea and the management of the epidemic. The Honorable Minister who spoke before me mentioned very important the impact of the COVID on the economy. When we had the first wave, we had to practically block everything. People could not walk. People must have the mask. People should not travel because our country is one island and mainland. So all this had very negative impact on the economy apart from the health. We did very well on the health aspects, as I could mention some political and strategic actions of a rapid response that got very good results in Equatorial Guinea. The creation of the political commitment with the action of the National Technical Committee for the first fight against the disease. There were two committees, the technical and political committee. And the political committee was actually taking decision based on the recommendation of the technical committee. And despite the crisis, the economic crisis, political commitment is very, very important. And we were lucky that most of our requests, we were not prepared like all other countries, we were not prepared to. But most of our requests, they were delivered by the government. We didn't have respirators, we didn't have trained people. We had to import technology from Cuba, around 77 medical doctors. We equip 3 of our hospitals with all the necessary equipment for emergency. And then the economic aspect, at the beginning, all the positive cases were isolated in hotels. And it became very expensive for the government. All the positive cases were isolated in hotels at the expense of the government, which were not sustainable. So we had to create some practical hospitals in the stadium, in two of the stadium in the main country. So we reduced the curve, the epidemiological curve, to the control levels, to 1.3, 1.6% for 7 months. But then the economic part, how was it dealt with? The government had to identify the most needed people and started giving some food rations and so on. Many of the enterprises, there was a lot of solidarity for people who have been cut. Those who live in day-to-day small businesses, like bars, like this, they could not do anything. So the government has to invest, and with the solidarity, we started to support them. And then we were very much concerned about the migration. The migration, we were very strict about the migration, about the flights, about the ships. But then we realized that with that, Equatorial Guinea is not a very agricultural country. We depend mainly on the oil. So we import from Cameroon and Gabon. If you close the borders, then what's going to happen? So we release the boats that were actually bringing agricultural products and so on. With the first wave, that was okay, but the government could not continue affording it. So when the second wave came, we were already more or less prepared. Agriculture, there was a commission that was going all over the country to collect whatever agricultural products were produced to bring them to the main town, and these were given free of charge. This is what I'm talking about, political commitment. Now, we talk about production of vaccine. We actually, in the malaria project, there are some people from Tanzania here, they will know the Sanaria. Equatorial Guinea has invested about $40 million to help develop a malaria vaccine in the country with the Sanaria. Sanaria, this is an American university which is actually developing a vaccine. Now, when the COVID came, this is the same structure that we use. The lab that we were using for the development of malaria vaccine is what we were using actually for COVID. And this was a big advantage for us because it is a 35 lab, and then we could actually isolate all type of things, virus and so on and so on. So we were very lucky on that aspect. This was part of the commitment. Now for the vaccine, we already vaccinated about 147,000, I have it here, Yeah. We have vaccinated 148,579 people. And we have got a target of 850,000 population in order to have the 70–80% immunity that we're looking at. Now, these vaccines were donations from China, 340,000 doses. Then our government, just a week ago, we managed to bring in 500,000 doses of vaccine. And I have to add something. When we was talking of equity in vaccine production, distribution, and utilization, the Chinese government with the Sinopharm, we had already paid completely, cash about $10 million for the 500,000 doses. But to get them to Equatorial Guinea was a big problem. So we had to send planes, our plane, to go and carry them. Besides the fact that once the Sinopharm was recognized by WHO, the demand is so high that although we had paid, there were not enough production for them to send us the $500,000. So these are the type of difficulties that if we don't have enhanced our own production, whatever, even if we have the money, we would not have the access because we have had such problems. We had an advantage that when the COVID-19 started in China, ignoring that it's going to expand to be a pandemic, our government helped the Chinese government with $2 million. So that's why the Chinese, in response, when this happened, they were able to give us 340,000 doses free of charge. So these are the type of experiences that I want to share. Political commitment, then the impact of the COVID on the economy, national economy, because we had to close the bars, we had to close everything for almost 3 months, and this was very, very, very negative on the economy. And the solidarity is also there. National solidarity is very, very important because when people didn't have something to eat, apart from the government, most of the enterprises, they were actually giving food to people. So it would have been very, very negative for us if we didn't have this type of solidarity, political commitment, and even the political commitment helped us. We didn't have enough doctors to UC, intensive care, for intensive care. So we had to import doctors for intensive care while we were preparing our own doctors. So this is the experience I wanted to share with you about Equatorial Guinea. Right now, we are down. The infectivity level is about is below 5. It's about 1.30%. So we have really reduced it. We are trying to maintain it. We hope we will be able to do it. We have got already some experience, but it's very costly if we don't mobilize our own resources, our own solidarity, and of course our partners, they should be able to come in and support us now that we need them, because we realize that most of them, they need us, they need our resources, they need our petrol, they need our agriculture. So it's good that when we need them, they should also come in, not only for our resources, but also to support us. Thank you.
Thank you very much, Honorable Minister from Equatorial Guinea, sharing your experience with us. We realize that African countries have nearly the same experience, and you have shared with us some of the challenges you went through to acquire vaccines, very expensively, I must say, in spite of the fact that you first got a donation. And we do hope that your struggle to develop COVID-19 vaccines will come to pass, because you already had a foundation of developing a malaria vaccine. We also want to thank your country for the political commitment and the solidarity from the entire community, knowing that you depend majorly on oil, but also people have to be fed during this time. I see we have been joined by another colleague, Your Excellency Rashid Aman. You're most welcome. We are happy to have you. Dr. Musenero, I do hope you're back online.
Yes, I am back.
Very good. We are happy to have you back. I want to give you opportunity to finish that discussion on vaccines so that we can move to some other topic.
Okay, thank you. As I was saying before I got disconnected, is that right now we have a two-pronged approach or three-pronged approach. Of course, we need vaccines immediately to vaccinate the population, and we're committed to procuring the vaccines. As the Honorable Acheng, you know that, it's in your docket. However, the other one, and the President's commitment, is to have the country rapidly develop capacity to produce the vaccines, both the fill and finish of approved vaccines, and there are negotiations going on with private sector and other investors, but also to produce our own vaccines. As I mentioned, 2 of ours, we have 2 research hubs which have advanced. They have been working over the past 1 year, and we have 2 candidate vaccines right now going through animal trials. The additional work that we would want is to make sure that there is research support to vaccine usage, because as we know, the vaccines are new, and applying to making sure that we have additional research to better refine the impact of these vaccines on our population, and to provide that information, and that support is additionally being put in place to support the research, the field research, including the communication and the receptiveness of our population towards vaccines. So we also have made a lot of advances in diagnostics, because for an epidemic like this, if you are able to diagnose, you should be able to identify where the virus is and manage to control. And within the next week, we should be putting down our first building, our first factory, that is to produce PCR diagnostics. So that is what we've done, apart from the procurement, which is with the Ministry of Health, but the science support, because we believe that if we are not able to provide, and going further as the Minister of Science, I would really like to, for us on the African continent regionally, to come together and bring our scientists and make a network that ensures that the continent can access and make and utilize the knowledge bases and even the infrastructure we have to make sure that we address a lot of these vital needs and not remain very dependent. Thank you.
Honorable Minister.
Yes, please.
I've been advised and guided that Dr. Rashid Aman is representing the Minister of Health, Kenya, and he is the Health Chief Administrative Secretary.
Thank you.
Thank you very much. Thank you very much, Dr. Musenero, for sharing with us some of the insights into ramping up production, not only for the vaccines, but also for other necessities during this time of the pandemic. Allow me to welcome Dr. Rashid Aman. We are happy to have you join us in this panel. We have just a very great discussion coming in from Zimbabwe and coming in from Equatorial Guinea. I want to turn to Kenya. Would like you to share with us some of your experience in case management of COVID-19 patients. We know that it is not cheap to treat critically ill patients, but we also know that during the years, Kenya has tried its best to set in place a very robust health insurance services for the population. You could give us some highlights on how you're handling the pandemic, both in the public and the private sector, but also taking care of other disease conditions. Over to you, Dr. Rashid.
Thank you very much, Honorable Minister. It's a pleasure to join you. Of course, we were invited the Cabinet Secretary, but he's tied up with other tasks. So I'm stepping in to. You can hear me? I hope all of you.
Yes, Dr. Rashid, we can hear you. I'm only going to request you to increase the volume of your system. Professor Tony Oyana, mute the other participants, please.
We have done that, Honorable.
Let me just get closer to the mic.
Yes.
See if it improves. It is improved now, I hope.
Great, go ahead.
Good, good. So, Honorable Minister, I was thanking you for the opportunity, this very important forum that you have been part of in putting together and organizing and bringing players from Africa to come and discuss their experiences with the COVID-19 pandemic. It has been truly a testing time for all of us, and I'm sure that every country has a story to tell. I'm happy to share with you some of the things that we have done as Kenya. The pandemic is still raging. We are not yet out of the woods, and therefore we need to continue to tighten our protocols and approaches that we are using to contain the disease. We in Kenya recorded our first case of COVID-19 on the 13th of March, 2020. As of the 27th of this month, we have 182,600 cases, confirmed cases. We have recorded 3,595 deaths so far through this pandemic. This translates to a case fatality rate of about 2%, which I think is what we are seeing in most African countries, somewhat lower than what is seen in some of the other Western and other countries outside of the tropics. We have the disease spread throughout all our 47 counties, with Nairobi remaining an epicenter because of the large population and the range of activities within Nairobi. It has remained as the epicenter. But lately we are seeing a spread, unusual spread of the disease in parts, especially around the western borders with Uganda. I'm sure Uganda is aware of what we are seeing now in Busia, Siaya, Kakamega, Bungoma, and those counties around the border where we know that the Delta variant is really the predominant variant. Most of our cases, the confirmed cases, fortunately turn out to be asymptomatic. We have recorded that from between 90 to 93% of confirmed cases will tend to be asymptomatic. And therefore, we'll have to deal with about 7 to 10% who are symptomatic or pre-symptomatic, who may then progress to requiring clinical management. I think this has been a fortunate thing, and I'm sure most other African countries see the same level of asymptomatic cases as compared to symptomatic cases, because this has made it easier for us to really deal with this pandemic, particularly at the level of case management. Given our limited capacities, given our weak health systems, I think this has been a fortunate thing to see that we have very few symptomatic cases. We have, through this period of time, experienced 3 waves of the virus. We have a wave. The first wave happened in July 2020. Our second wave happened in November 2020. The third wave in March 2021. And some of our modelers are predicting now that, looking back at these waves, that there may be some periodicity to these waves, that every quarter, every 3 months or so, we are likely to have a surge. Actually, right now, we are anticipating that we will be having our 4th wave probably sometime in mid-July or so. With what we are seeing, the spread of particularly the Delta variant moving in and sweeping in towards now the eastern side of the country, we are likely to see a wave in mid-July this year. We have about 5,592 cases of healthcare workers, our frontline workers. And we recorded about 40 deaths of our valued healthcare workers. In terms of our testing capacity, we have tried to operate at whatever capacity that our resources would be able to take us to. And so far, we have been able to conduct about almost 2 million tests throughout the period of the pandemic. Among these 2 million tests, our overall positivity rate is 9.4%. But of course, we know that positivity rate will change with time depending upon where we are on the curve. In terms of capacity for testing, it still remains, we believe it still remains somewhat of a challenge, because according to the WHO guidelines and the targets that we need to be testing, I think we are below that. And the reason we are below is because of difficulties. Number one, most of these the testing that we do is PCR testing. It requires sophisticated equipment and reagents and costly reagents, which are also in short supply in the global chain, although this has now improved. But through this time, we have been able to build this capacity. We currently have about 48 public sector laboratories that routinely test and report to our national database, including, as well as 13 private laboratories. Our gold standard still remains the PCR test, although we are also doing antigen testing now, sometimes at points of entry, just as a screening procedure. But the PCR still remains our gold standard in these laboratories that I have mentioned. In terms of surveillance, we have enhanced surveillance at points of entry with screening and follow-up of visitors from high-risk countries. We conduct a regular risk profile for countries with circulating virus and variants, and equally then adjust our protocols for entry of nationals from these countries. One of the areas that we have really done, I think, quite well is in terms of the surveillance for variants. I think we started fairly early to begin to look at genomic sequencing. Our research institutions have been doing that. Through this effort, we have been able to very quickly determine where the areas of spread of new variants as they come into the country, how they come in, and how they spread in different regions. This is a capacity that we intend to continue to build, because it's very important for us, knowing and seeing the evolution or spread of this virus and the capability to mutate and increase its transmissibility and maybe also its pathogenicity. It is important that we have a very good system of genomic surveillance. The little capacity that we have in this area, we are sharing it with our neighbors. And in fact, we are a WHO designated center for supporting genomic sequencing for our neighboring countries of Tanzania, South Sudan, Burundi, Somalia, and Comoros Islands. And we are currently doing this in about 3 different institutions, national institutions, and 1 international institution. Let me move now, before I move on to vaccination, I would like to talk a little bit about what the moderator pointed out that I need to talk about, is how we have dealt with case management. We realized, and I think the story is the same in all other countries, not only our African countries, but countries all over the world, is that we realized very suddenly that we were confronted by a very, very difficult threat that we may not have been prepared for in terms of our health systems generally being weak at the level of the primary health care, and even at the points of referral and the specialized hospitals that we have, limited in number, limited in emergency care and treatment. And these were some of the very early challenges that we anticipated. We tried as much as possible within a devolved health system, because in Kenya, our system is devolved health system. Health is a responsibility of the counties. They get resources to be able to support their activities in health. As a national government, we support them, we help them build their capacity. But it was a bit challenging to try to build up the capacity, particularly of our counties, and to bring it up to a level where we would feel we were prepared to some extent to meet these waves, huge waves that would end up overwhelming our health system. We invested quite a bit of money in the counties. We provided them with resources, and we gave them targets to build capacity immediately, first of all, by building up COVID beds where people with COVID who need hospitalization could be put in. We also urged them to up their ICU capacities and increase the number of beds that they have within their various facilities. This has been a long journey. Some counties have been able to meet those targets. Others are still struggling with it. But in the last particular 3rd wave, which was a great challenge for us, we did experience some level of overwhelming of our facilities, even to the extent of the problem with oxygen. And I think Uganda knows very well now, because I know Uganda is going through a similar episode as we went through during our 3rd wave of lack of oxygen, for instance. Of course, coupled with the lack of ICU beds and most critically, lack of human resource who are trained to be able to deal with ICUs and critical care. That is an area that, of course, you cannot fix very quickly. So there will always be a limitation, even if you have enough ICU beds, enough oxygen, you will still have a problem in the area of human resources. These are areas we have identified. These are areas we are now moving forward, trying to bolster, so that when as this pandemic runs its course, or perhaps another pandemic comes in future, that we have a stronger health system where we have improved our HRH, we have improved physical facilities, we have improved access to materials that are required, commodities that are required for health management. So I can say that in the 3rd wave, we were a little bit challenged, but fortunately we were able to ride that wave and come down. But now we are facing the Delta variant and another wave, and the same problems face us, but we are trying to prepare for them as best as we can by facilitating, first of all, in the period between that 3rd wave and now, we have been able to improve on availability of oxygen to our health facilities. We have beefed up the oxygen plants within those facilities. We have piped oxygen into facilities. We have set up tanks, storage tanks in some of these facilities. And we have worked with the private sector, the British Oxygen Company, which is the major producer of oxygen. We have been working very closely with them for them to ramp up their capacity to be able to produce oxygen, including reducing supplies to other non-essential areas so that these supplies can be channeled towards the needs in health. So I believe that we will see what happens at the end of this upcoming phase of the cycle that we anticipate will happen fairly soon. Now, if I come to the area of vaccination, Honorable Minister and Honorable Ministers, we received our first COVAX consignment of about 1.1 million doses, which immediately went into arms. About 1 million of it went into arms as a first dose. And then we had, as you all recall, that there was the global crisis of access and availability of the COVID vaccine. The one we are using is the AstraZeneca one, manufactured by the Serum Institute of India. The rise of the pandemic and the Delta variant in India, and subsequent ban on export by the Serum Institute of India. That is where our COVAX vaccines were coming from. So we were stuck only with what we received. We quickly ran out of that with the first dose, but we were able to provide at least up to 300,000 cases with the second dose. We also received some donations. We received 100,000 doses from the Indian government very early on. And we recently received another 350,000 donation from Denmark. So with this about under just 1.5 million doses, I think we will just be able to give second dose to most of those 1 million who got it. This is still a very low number. It's still a very low number in relation to our population and in relation to the targets that we have set in terms of the number of people that we want to vaccinate. We had very lofty ideas to vaccinate at least 30 million of Kenyans out of our population of 50 million in the early stages, receiving most of these from the COVAX facility. Of course, we expected at least 24 million doses from the COVAX facility. We have only received 1 million, as I'm telling you, and you know where the problems are, why we're not receiving the rest of the vaccines. We're still in that situation. I heard discussion now, and there has been vibrant discussion around what do we do as developing countries faced with a situation like this. I can tell you that when the pandemic first broke out, when we had the problems with supply chain of simple things, such as PPEs, masks, and others, we quickly encouraged local industries that are producing masks, the coveralls, the PPEs, which I think we're even exporting to some countries in the region. So, I mean, that teaches us that if we have a resolve, when we are faced with a challenge, if we put our minds together and put our resources where it matters, we can overcome. And I think when it comes to vaccines as well, I'm very happy to hear that countries like Uganda, Rwanda, South Africa are quite advanced in terms of, going down that road of producing their own vaccines, whether it is a fill and finish or whether it is an entire setup that begins from the very early process of development all the way to the product. This is the direction we need to go as Africa. I know that there's vibrant discussion spearheaded by the African Union and the CDC Africa. There are discussions in that area. As in Kenya, we're very keen on that. We are having very high level discussions to see how we can begin something, even if it means beginning with a fill and finish first, but then moving on. However, the fill and finish approach to me is something that I think we need to consider very seriously, because by saying fill and finish, we are making the assumption that the problem is the fill and finish. The problem is not the fill and finish, we know that. The problem is the availability of the product itself along the line. So we need to go down, I think, a little further. We really need to develop the basics that are required for us to get into this biotechnological space where we can be able to produce this. Uganda is talking about producing PCR reagents, the enzymes that are required and all of that. It's a doable thing. It's not very high technology, but it can be done. There is possibility to actually engineer vaccines, test them and develop them and put them out there. Many countries have done it. Many countries with lesser resources than us are doing it. Cuba has about 4 vaccines that they have done. There's no reason why as African countries, if we put our minds to it, if we put our will and resources to it, we can do it. I think that's the direction that we need to go. That's the strong message that we want to send here from Kenya, that we are keen on that area. And we want to work with countries within the region and see how we can together be able to build these capacities. So that is on vaccines. I would like to just highlight some few challenges that we have noted during our response. Funding gap was a big problem, mobilizing resources, and we had in certain cases to go to the big lenders and get funding to be able to support some of the activities. And we're not talking only about the health aspect of the response, but also the economic aspects and the damage that was done to the economy, the alleviation of the suffering of people as a result of this economic decline.
Everybody opportunity to talk. I'm now going to give Professor Ibingira.
Okay, I think, yes, I don't want to take a lot of time. I hope that I have touched on some of the key highlight areas, and I'll be available to respond to any particular question that may be addressed on my remarks. Thank you very much, Honorable Minister, and all the
Mr. Rashid Aman, for sharing with us the Kenyan experience and also encouraging the African countries that we can do it. And we are doing it. Not only are we managing COVID, but we are surviving. And I know for sure that Africa will not be the same after this pandemic. We need to discuss a very important topic, and that is the topic of human resources. And I want to turn to you, Professor Ibingira, as someone who is coming from the training universities. In all the discussions that we have had, you have heard from the health ministers that one of the most important resources is human resources. And we do get challenges with human resources, usually when it comes to clinical care. But with this pandemic, we are also getting challenges with human resources in many other areas, many other pillars of the pandemic. As somebody coming from a well-known training institution that is recognized internationally, we want you to share with us some of your insights in quick training of human resources. And when I talk about quick, I'm not meaning, the long-term training where you plan for specialists, but we quickly need people with skills to come in and